Before we start, that's recording in progress. So this will be recorded and it will be on our website in 3 or 4 weeks after Lauren has had a time to clean up the captions. Welcome to everybody who's here. And I think everybody, most people look familiar to me, so I assume you're all familiar with our accommodations, our accessibility, the captions. You go to the CC screen at the bottom. For this meeting, we also have available captions in Spanish. And the way you would access those captions is to go in the cart, go in the chat, and there's a link there that will connect you to stream text. And if you look in the upper left-hand corner, you'll see a choice of languages. And David has also just explained that in the chat. So I don't know if anyone's interested in following up with that. What will show up just in regular captions is English. I also, before we start, just want to welcome everybody who's here. I have a feeling there's something I was planning to announce, and I've been trying to think of it for the past hour. So if anyone remembers anything from our board meeting that I said we were going to talk about, please feel free to speak up. I did go over the CART transcript and couldn't see anything. So this is our next to last meeting for this 2023-24 season. And this is a topic we've been thinking about doing for quite a while. It's about diversity in the hearing professions. The panelists are going to discuss a wide range of things. Each will start by giving a presentation with her particular field. But there are a lot of questions that we've asked them to address, whether hearing loss affects different ethnic groups in different ways, how is the audiology profession, which has traditionally been white and I think female, beginning to change in response to more people coming in as hearing aids and as cochlear implants become more available. We'll wait and just ask those questions when they're asked. So I'm going to introduce all three of our speakers, and then I think they'll probably tell you a little bit more about themselves. The first speaker is Karen Beverly-Ducker, and she is the Senior Director for Multicultural Practices at ASHA, the American Speech Language Hearing Association. She's an audiologist, she's a certified association executive, and she's an ASHA fellow. She has a non-ASHA background. She worked in the public school system, in the federal government, in occupational safety and health administration, and she's worked in private practices. She has 3 speech language pathologists on her team at ASHA. She has also written many articles that focus on multiculturalism in the communication sciences. And she's a co-editor of the book Exploring Cultural Responsiveness, Guided Scenarios for Communication Sciences and Disorders Professionals. That's a mouthful. Our second speaker is Diane Martinez. She is an audiologist, a doctor of audiology, and she is also a PhD candidate in the Department of Communication Sciences and Disorders at the University of South Florida. Some of you may have heard her speak at convention a year or 2 ago. I think several of us did, and just one of the reasons we wanted to bring her in for this program here. Prior to going back to school to get her PhD, she worked as a cochlear implant audiologist at the University of Miami's Department of Otolaryngology Cochlear Implant Program. During her 15 years there, she provided cochlear implant programming and evaluation services for adults and children. And she also provided clinical education to audiology students, interns, externs, and domestic and international visiting professionals. Her current project includes evidence-based practice in cochlear implant programming and managing the adult Spanish-speaking cochlear implant. And then the third person on our panel is the Spanish-speaking adult cochlear implant. Lyssy Pastrana, who some of you probably know, is on our board. She has had hearing loss since age of 35. She gradually lost her hearing and she began wearing hearing aids in 1989. In 2022, she had cochlear implant surgery. She has been very active in the Spanish community in East Harlem, and she she realized that there was really a lack of information on hearing loss, and she decided to remedy that. She created Lyssy Warriors for Hearing Loss. And if you come to our Walk for Hearing, you'll actually see Lyssy and her team. She's been holding workshops since 2022 at senior centers. She is, as I said, a member of the board of the New York City chapter of the Hearing Loss Association, and she is also on the Bronx Disability Advisory Council. And in her spare time, she's a photojournalist. So we're going to begin with Karen, and then Diane, and then Lyssy. And if you would hold your questions until all three have spoken, that's usually easier. I don't know if the speakers prefer that or not. If you'd rather have people ask questions as you're speaking, just let them know. I find it goes along more smoothly if people wait. So Karen Beverly-Ducker, you are on, and I'm going to mute myself. Welcome.
Thank you. And I can only see Diane. Can you see my screen? Yes, thank you. Thank you, and good evening, everyone. Thank you for inviting me to join you. I've had the opportunity to speak with some of the chapters in the state of Maryland, but this is my first to join in New York. Happy National Speech Language Hearing Month, formerly known as Better Hearing and Speech Month. And I always used to wonder, better than what, but we have a new name now. I want to, I'm not advancing. And why am I not advancing? Okay. From my ASHA background, we typically have to first share disclosures that may not be necessary here. You can see them on the screen, but the one that I will share with you is a personal disclosure that I tell everyone that I am blatantly biased in favor and support of audiologists and the profession of audiology, and I'm forever trying to recruit into the profession. So I want to be above board about that. I am also a member of the Dialogues group, and this group is a coordinated movement across the fields of hearing science and hearing healthcare. And the aim is to improve diversity, inclusion, equity, and access within the different professions represented. And again, you can read for yourself on the screen what the goal of the group is, but I wanted to share also because I'm going to be referencing some information from that group. As is often the case, words are used in different ways to mean the same thing and sometimes different things. So I wanted to first talk about what I'm talking about when I refer to race, ethnicity, and culturally and linguistically diverse. I'm referencing the US Census Bureau, and I'm sure you've all had the opportunity to fill out the census survey, and you come down to the section that asks your race, and you're given choices. So under race, the Census Bureau indicates race is Black or African American, American Indian, and Alaskan Native, Asian, Native Hawaiian, and other Pacific Islander. And then you have the option of indicating you are some other race or two or more races or multiracial. The census offers just the choice of under ethnicity of Hispanic or Latino or not Hispanic or Latino. And I do want to, of course, acknowledge, I know there are many additional ethnicities, but I am using the US Census categories. The term culturally and linguistically diverse, or CLD, is actually often used when the speaker is actually talking about racial ethnic minorities. I am very deliberate when I use that term, and I don't use it for that, because that's everyone. Everyone has a cultural background and everyone has a linguistic background. So again, I just wanted to share a little bit about the terms. I wanted to also share about the diversity of our membership. As I said, I'm a member of the Dialogues group, and we collected membership data. So for comparative purposes, this is from 2022. The reason for that, ASHA collects data at the end of a year, and then it is not released until the following year. So we just gained access to 2023 data. But the Dialogues group as a group shared their data. So again, this is from 2022, but it is still fairly representative of the diversity within the groups. Under ASHA, this is representing audiologists. ASHA represents approximately 234,000 members, of which 14,000 are audiologists. So the majority of our membership are speech language pathologists and scientists. But again, this represents the racial ethnic diversity using the Census Bureau categories of our membership. As you can see, and I'm actually covering up part of my screen with the pictures. If you look at ASHA, 91.1% of our members of audiologists indicate they are white or Caucasian. 79.9% of AAA, which is the American Academy of Audiology, and 72% of the American AAA. All of a sudden, I can't code switch into the acronym, but the American Association for Head and Neck Surgeons is otolaryngologists. And then you can also see what is the diversity breakdown of the United States. These numbers indicate that the hearing healthcare professions, which you already know, do not reflect the diversity of the United States. But in response, I want to just pose some questions to you for thought. We don't have to talk through them today, but for your consideration, should or is there a need for these professions to reflect the diversity of the United States? Why or why not? Should this be a goal that we represent the diversity of the United States? Why or not, why not? And if not, what should the goal be? So again, this table is representing audiologists and hearing healthcare professionals. At the end of 2023, but again, it's fairly comparable to 2022, a little more than 1,200 of our members self-identified as being from a historically underrepresented racial ethnic minority background. One of the things that was listed on my disclosure slide that I did not go into, but one of my non-financial disclosures is that I am a member of the National Black Association for Speech, Language, and Hearing. And that is kind of a mirror organization with a predominantly Black African-American membership, all speech pathologists and audiologists. With almost representation in terms of numbers of 14,000 versus 234,000. We used to joke, and I've been a member for 30 years, so for a long time, we used to joke that we collectively could come together and list every single racial ethnic minority audiologist in the United States. And that's because there weren't that many of them. And when I say racial ethnic minority, I'm talking about not just the Black audiologists, the Asian audiologists, the Hispanic, etc. We no longer can do that because now there are about 1,200. That's good news in terms of our numbers are larger, but the total number of audiologists has also increased. This does continue to be a predominantly white profession. In the overall picture, 1,200 is not a large number, but another question, what number and what efforts would be needed to change the view that audiology is a white profession? I want to shift just a bit and focus on disparities in hearing healthcare from the provider's perspective. And when I think of disparities, I think about the contributing factors or those things that contribute to disparate services. To me, a significant contributor to disparate service delivery from the provider perspective is a lack of cultural responsiveness. So cultural responsiveness is understanding and appropriately including and responding to the combination of cultural variables and the full range of dimensions of diversity that an individual brings to interactions. And that's quite a mouthful. So to break it into components, when I talk about the range of dimensions of diversity, what are the different things that make up the diverse you? So we're talking about age and gender, we're talking about gender expression, sex, race, sexual orientation, etc. And in terms of the individual, we're not only talking about the client, patient, student, we're talking about their family, their caregivers, their care partners, and the service provider. So, thinking about the range of the dimensions of diversity, for quite a while we have thought, we've been taught, we've been told that we don't see differences. And a lot of times people will say, I don't see differences, I just see you, we are the same. We were taught that it's impolite or inappropriate to see or to talk about differences. But the fact is, there are differences. To me, cultural responsiveness is knowing when a difference makes a difference. There are differences. So not every difference makes a difference in every situation. For example, if I went into Diane's clinic for an audiologic evaluation, the fact that she and I have, I'm assuming, different shoe sizes and maybe shoe styles wouldn't really make a difference in that evaluation. The fact that we may have differences in our linguistic backgrounds may make a difference and impact services. So that to me is cultural responsiveness. In terms of how ASHA is trying to gauge the cultural responsiveness of our members, we sent a survey out to approximately 1,600 audiologists, and we asked many, many questions. This is just an example of the things we were asking, and the results were divided. These were all early career practitioners. So audiologists who had either practiced less than a year and those who were a little over a year. There are a lot of reasons why we chose this particular snapshot, but you can see on the screen a sampling of the questions we ask and their responses. Just sharing as we look at the numbers. Of course, there are different thoughts come to mind, but we can discuss the results and the associated implications at another time. For the next three slides, I've removed the references for ease of reading and also for spacing, but I can provide them. So in response to, I wasn't quite certain if I was to respond to several of the questions that was posed to the group or if we waited one time. So I'll just throw out my responses to the questions now and we can backtrack. But in response to, does hearing loss affect different racial ethnic groups differently? In all honesty, I went back and forth between wondering if the emphasis was on the impact of a hearing loss for different groups, or if it was referring to incidence and prevalence of hearing loss in different groups. So I responded to both. On this particular one, these are quotes from a variety of studies. As I said, I've pulled out the specific reference, but I can give them to you. And again, the slides will be made available to you, and you can also read them on the screen. But just some examples of hearing loss being different in different racial ethnic groups. Non-Hispanic white adults are more likely than adults in other racial ethnic groups to have hearing loss. Non-Hispanic Black adults have the lowest prevalence of hearing loss among adults ages 20 to 69. And Black Americans 65 years and older have much better hearing than their white counterparts. I'll drop down to the last bullet. There have also been studies looking, because of the phonemic inventories, the sounds of different languages, since they are different, and some are clustered more in lower frequencies and some more in higher frequencies. Some studies have indicated that the impact of a hearing loss is less on some languages. And also there may be influences on, for example, programming hearing aids. So again, since I wasn't certain from which perspective, I just pulled a couple of examples of things that impact hearing. And I looked at incidence and prevalence. Sickle cell disease, for example, is more prevalent and it has a higher incidence in Black African Americans, but it does occur in other races and ethnicities as well. And those numbers are reflected. Tay-Sachs disease, I don't have specific numbers, more commentary of the group that it is more prevalent in. Otitis media, they're among white children, 7%, Hispanic children. So as you look at the list, the numbers are going down according to the racial ethnic group. And just a commentary related to cholesteatoma. And again, I just randomly chose some things to share. It is typically highest in Caucasians, followed by Africans or African Americans, and then by Asians. So in terms of when we talk about health disparities and healthcare access disparities, again, these are comments pulled from a variety of studies looking at disparities. So for example, in hearing healthcare, there's evidence of racial disparity in the management of a variety of clinical conditions, including hearing loss and vestibular schwannoma. The timing of cochlear implantation has been found to differ based on, according to this study, based on race and ethnicity, with Black children being 56% less likely and Hispanic children 30% less likely to be implanted prior to the age of 2 compared to white children, regardless of insurance status. And again, there are a couple more bullets that make reference to health disparities and health access disparities. The factors that produce these disparities in the hearing healthcare professions are multifaceted. Even within the same healthcare system, there are biases that may influence the quality of care for minoritized racial ethnic groups. In part, it's likely due to a lack of diversity within the hearing healthcare professionals, as well as a lack of cultural responsiveness by hearing healthcare professionals. As I conclude, I wanted to be sure to address, again, I was not certain which of the questions I was to address. So the first one I talked about a little bit. Our numbers are changing, our percentage is not changing. And there are a lot of things that account for that. So I'm going to go or focus on what accounts for the disparity in these different fields. And I see this as twofold. There's disparity in the representation of professionals due to factors such as a general lack of seeing themselves in the profession, a lack of knowledge about the field, the cost of training in the field, the length of time needed, the rigidity in terms of how the requirements may be met, competition for a limited number of slots in the training programs, the requirements like the praxis examination, which may be more familiar to some of us than others, completion of the clinical fellowship, and also definitions of what is a professional that does not take into account or recognize cultural influences. For disparities in service delivery, it is, again, to me, a lack of cultural responsiveness. Then I want to finally talk about a shortage of professionals of color, if that means that patients of color are less likely to seek care. And I did specifically, because my answer is going to be more my thoughts versus any research study. I think, yes, for some patients who have a preference or who may feel more comfortable with a hearing healthcare provider who looks like them. But that means there's the associated thought or the assumption that because we look alike, that we'll think alike, that our experiences are alike, our beliefs are the same. So an example that hopefully will convey, I identify as an African-American woman. As an African-American woman, I may say to another African-American professional, sorry, I'm late for today's appointment. My kitchen was rough and I couldn't come out looking that bad. I don't have to explain to some African-Americans what I'm talking about, but in general, other groups will not, you'll think of my kitchen, like, what does that have to do anything? Long backstory, the kitchen is our hair. I may not be as willing to share about some of the home remedies that I may have tried because I don't want to be judged or, again, to have to explain. I may not be as open to sharing how I ask the elders in my church to lay hands on me, because again, if that isn't your background, I don't want to have to explain, justify, or feel as though you're judging me. But on the other hand, that does not mean that every single person every single African-American person has the same experience. So, to me, kind of bringing it full circle, I think that we sometimes refer to that as race matching. So we're race matching the professional and the patient client, but I think that reinforces the notion that competent care, clinically competent care, is different from culturally competent and responsive care. Ideally, I would hope that patients will recognize the need for hearing healthcare services, and they will seek out and find the hearing healthcare professional who will listen, is concerned, empathetic, knowledgeable, etc., across multiple dimensions. And that's it. I'll stop sharing. And
Thank you.
over to Diane.
Thank you. So we're going to move on to Diane. Diane. Okay.
You guys see that okay?
Yeah, we see you.
Okay, perfect. All right. Well, thanks you guys again. Thanks to the committee for having me. So we're going to be looking at cochlear implants, access, and language considerations.
Diane, can I just say one thing? This
Yes.
is complicated material and it's hard to read the captions and look at the slides. So go slowly.
Okay, sure.
Okay, thanks.
Sure. So cochlear implants have been approved by the FDA since 1985 for adults and since 1990 for children. But they still happen to be overwhelmingly underused. Only about 2.8% of those who are potential candidates even receive a cochlear implant. The Hispanic population continues to grow. According to the US Census, the city of Miami, for example, is comprised of a 70% Hispanic population. My caseload looked very much like this. As a matter of fact, my caseload when I worked at the University of Miami was about 70 to 75% Spanish speakers. again, I just wanted to sort of reiterate, I know that it was mentioned earlier of my background, but before coming to USF, I did work at the University of Miami. And so that's why you see the University of Miami's logo on these slides. And so one of the most important elements for candidacy and tracking progress are the speech perception tests. And currently, little is known about bilingual performance. At the University of Miami, we had a really unique opportunity to be able to look at this patient population. So several years ago, a colleague and I started to notice differences in the way that the monolingual Spanish would test and the way that the monolingual English patients would test. And we wanted to see if the Spanish speakers would perform better than the English speakers. And we wanted to see how did this look in terms of cochlear implant candidacy and testing. So we had a grand total of about 85 participants. Let's see. And that's the breakdown there. That's the English only group and the Spanish only group. Of the 85 participants, we had a subset of 12 true Spanish-English bilinguals. And of those 12, 7 of them were primarily English speaking. And 5 of the 12 were primarily Spanish speaking. And all of these patients lost their hearing over time. So they were all born with hearing, but progressively lost it over the years. And they were all patients who had cochlear implant surgery done only on one side. If any of these patients had hearing on the opposite ear, so the ear that did not have a cochlear implant, that ear was plugged, so that we were only testing the cochlear implant only condition. So we proposed that these were hypotheses. We proposed, number one, that the primarily Spanish speakers were going to perform better on the Spanish tests than the English speakers on the English tests. And then within that subset of the 12 bilinguals, we said that the bilingual patients will also perform better with the Spanish tests over the English tests. So for the cochlear implant evaluation, and this is where we determine if the patient is an actual cochlear implant candidate, we analyze the understanding of words, sentences, and sentences in noise. And so this is how we did the testing. So you'll see here, this is the person's head. They're sitting at about 1 meter from the speaker. And from the speaker, it comes the noise and the signal. So the signal meaning either the words or the sentences in noise. I have to add that all this testing that's done that you see here is done aided. So it's either done with a hearing aid or it's done with a cochlear implant. And so the difference is, if you see on the graphs here at the bottom, you see the 0 across the horizontal axis. This is the 0 months time point. 0 months means that was before surgery. So that was before their cochlear implant. And so if it was before the cochlear implant, that testing was done with a hearing aid. And all the time points after it, you'll see 1 to 2 months, 3 to 6 months, 7 to 12, and so forth. All of these months, this is where the patient was tested with their cochlear implant. So in figure A, the one on the far left, we see results for word understanding of Spanish speakers and English speakers. And on the vertical axis, you have the percent words correct. And on the horizontal axis, we have the different time points. So from before surgery at 0 to more than 24 months with the cochlear implant. Overall, Spanish speakers performed similarly before and after surgery on words as the English speakers. Both rise from approximately 20% to about 55 to 75% over time. In figures B and C, however, on the sentence tests, Spanish speakers perform better on the sentences in quiet and in noise when compared to the English speakers. I also have to point, I'm going to talk a little bit more about these two different lists. Some changes have gone on since we last did this testing. But yes, so again, Spanish speakers outperformed the English speakers on the quiet sentences and the noise sentences in noise. In quiet, there was about a 20% difference, and in the noise condition, there was about a 60% difference. So these are the results for that subset of the 12 Spanish-English bilingual speakers, and this is at the more than 24-month interval. We showed that the bilingual patients performed better on the Spanish bisyllable words over the English words, and they also did better on the Spanish sentences versus the English sentences. And so we thought, why are there these differences happening? Well, first, I should probably mention that there were several limitations to our study. One being that we did not review language dominance. We also did not look at socioeconomic status or the education level. We tested bilingual patients who had a level of conversational fluency, and they also use both languages in their day-to-day, in their family life and in their work environments. But this may not reflect the full spectrum of the Hispanic population. Also, we use the Latin American hints, which are a type of sentences they're in Spanish, because that's what was used at that particular time. It wasn't until relatively recently that the Spanish AZ Bio sentence list had become available. I started the PhD program here at USF in August of 2021, and it was not even a year before that we had started using the Spanish AZ Bio. Might have been just a few months before I got here. But there are, many things to take into consideration when we're thinking about, these differences. Why are there differences between the languages? Well, and why are the differences in the results that we saw on the previous slide? Well, it could be that there may be different levels of proficiency in each language. At what age did that second language come in? At what age was it acquired? For the bilingual recipients, maybe Spanish really is easier to hear than English. It may be easier to hear or understand. Or maybe the Spanish materials may just be that much easier than the English test. And then we also have to take into consideration the cultural differences. With the Hispanic community, it's very, very communal. And so a lot of times you're going to find many family members under one roof. It does tend to get a little loud. Sometimes the Spanish is the language that stands out a lot more. And so maybe that's why people are doing better. So we weren't really sure. So something definitely that we are continuing to study. But what does this mean for you as a patient? So in a nutshell, it's very important right now to test in both languages for a more comprehensive picture of your abilities. So for example, we take a native Spanish speaker who lives in the United States, and they use English at work, but they mainly use Spanish at home. In this case, the patient may report struggling more at work, which is where they're using the English. So for candidacy purposes, they also have to be tested in English. If we tested them in Spanish only, it may look like they're not a candidate because they do so well. Take another case. Consider a retired Spanish speaker whose family mainly uses English. And so maybe that person too should also be tested in English. So, we like to make these recommendations and figure out how we're going to test these patients, based on these results, based on their lifestyles, and their home environments. And we also want to think about, tracking progress over time. Wanted to share a story about one of my cochlear implant patients, and she was probably in her 70s when she got her device. She actually started with a colleague of mine, and my colleague was monolingual English speaker. My colleague happened to move away, and so this patient ended up on my caseload. Well, when she came onto my caseload, one of the physicians came to me and she said, "Diane, can you test, Mrs. So-and-so, because her scores on paper from the sentences in the booth, when the testing is done in the booth, really is not reflective of what she's doing with me in the visitation room." And so I go to look, and yes, so that patient was tested only in English, and and maybe rightly so. This particular patient was born in Cuba, but she had come to the US maybe in her teens. So her English was beautiful. And so, my colleague tested her in English because her English was amazing. But when she did the English AZ bios, the sentences, she was only scoring 20%, which was, again, not at all reflective of what she was able to do in her in face-to-face or in her day-to-day even. And so I said, so she was on my caseload, and so I told her, let's go do testing. I'm bilingual, and so are you. So we're going to test both in English and Spanish to see, what we get. And she said, okay. And sure enough, she still scored about 20% on the English sentences. And with the Spanish sentences, she was up at, 90 something percent in quiet. So huge gap there. So again, right now, until we can get more data out there, it's very important to test a patient in both languages. So these are our future directions, the things that we want to do going forward with our Spanish and English bilingual patients. We want to compare the AZ Bio English to the AZ Bio Spanish. We've actually started doing this here at USF. And some of our preliminary data is actually consistent with our colleagues over at the University of Miami. My friends had started doing some testing there, and they were finding that Spanish really is easier to hear in comparing these two sentence lists, and we are actually finding the same so far. The Spanish AZ bios are more complex in vocabulary. They're presented at a faster rate and a sentence length compared to the sentences that were used in the past. But more studies need to be performed because these newer lists, these AZ bio ones, are proving to be a bit tougher for the patients, and it may be more reflective of real world communication difficulties. And so from this, we want to, come up with some studies, come up with some protocols to be able to best test our bilingual patients and to make sure that we are capturing those who truly are candidates, and then to know how to deal with them in their post-surgery care as well. And so we're hoping that this study serves as a platform for other studies of bilingual patients. And so in the United States, behind English and Spanish is Mandarin. Mandarin is the third most spoken language in the US. And so hopefully those who speak Mandarin will be inspired, and hopefully we'll see some studies from that population as well. I'd like to acknowledge the great clinical team at the University of Miami and my research collaborators, particularly my colleague, dear friend, I consider her my sister, Dr. Sandra Velandia, and also Dr. Christine Din, one of the neurotologists there. Amazing people. Want to thank them for their contribution and support of this research. These are my references. And I thank you guys for your attention.
Thank you so much. I think we might have to go back to some of those slides when we get to the Q&A. Lyssy, over to you now, and you're muted, as you probably realize.
I want to start with my journey. Though I had lost some of my hearing at 35, or when I noticed at 35, I wore the hearing aid. Unfortunately, the hearing aids, they amplify the sounds that I was able to hear, not the sounds that I wasn't able to hear. Moving fast forward, as you know, I'm a photojournalist, and I have attended throughout New York City multicultural events. I think that the first time I saw a cochlear implant was probably 2007 or 2008, somewhere there, and I had no idea what that was. Mind you, I've been in the community, taking pictures at different events, multicultural. So I attend festivals, all kind of different activities within the cities. And moving fast forward, when I got my hearing test, and at that point I had graduated from hearing aids to the cochlear implant, I had no idea what that was. I got very, very lucky with my surgeon. He was bilingual. He spoke Spanish. And we developed this relationship. We talked about the choices. He told me about the surgery. I felt very, very comfortable with him. But at every appointment, while I was sitting in the waiting room, I didn't see any Latinos and I didn't see any Blacks. I saw Asian and white. When I got my hearing tested, or after I had my surgeries, that I would go for adjustments for my cochlear implant, all the doctors that I saw, the audiologists, they were all white. I built a relationship with my doctor. I built a relationship with the audiologist. And the first thing I asked them was, what does your outreach look like? Can you tell me what is your outreach? My surgeon told me that they had just had a big meeting at the hospital, and there was the topic was they were not getting in touch with the Latino community or the Black community. I had already thoughts in my mind, I have to do something to bring awareness to hearing loss, because I have never seen it throughout any of the events that I've been to. So I spoke to my audiologist, I spoke to my doctor, and I told them about this idea that I had about tabling information at events or at festivals, wherever I could. They have backed me up 100%. They got me in touch with different audiologists. They got me in touch with the manufacturer of my cochlear implant, and I built a relationship with them. The other thing that I also noticed was that in the Latino community, they were reluctant to get hearing aids or address even hearing issues. That's something that was not talked about. Once I started wearing my hearing aids and people asked me what that was, and I said, well, I'm legally deaf in my right ear, and they said, well, that's the sign of aging, and there was jokes about it. So I said, okay, I want to do this. I want to bring this information out to the community. Where can I start? So what I did was I started a senior citizen center. And still, when I do my workshop, because I also have a little workshop that I do with one of my audiologists, still the denial of it's part of aging. They have tons of questions about hearing aids, tons of questions about cochlear implant because they're not familiar with it. And it just seemed, to me, my opinion, that the whites, either they're doing more research or they're getting better information from the doctors, the audiologists, surgeons. I have no idea, but I think that there's a big lack of information on hearing loss in our community. So this is why I decided to create this organization called Lyssy's Warriors for Hearing Loss. I do not cater to any hospitals. I do not cater to one audiologist. Whoever gives me information when I table, this is what I bring to the community. I just did an outreach at a senior citizen. It was a pre-Mother's Day event. My information, my pamphlets, they were just flying off of my table. They had tons of questions. Most of the questions were more on hearing aids and the over-the-counter hearing aids. That now we're getting to hear about this, and I think that there's a lot of work to do in these communities. I think that we have to bring up these conversations. We have to educate our people that this is not part of aging, that it's okay if you have hearing loss. I've even heard, well, if I wear a hearing aid, I might be a target. In some communities, you may be a target. I know that myself. But we do have to address these issues, and we do have to educate our communities, because I don't think that the outreach that we're doing in social media is actually getting into the communities where we don't have laptops, where we have our seniors that don't even know how to manage their phones. They don't have access, or they don't know how to get this information, so they can do their own research, get the statistics, get to see who's the best audiologist, the best surgeon, the best place to get hearing aids. That is an issue that I have taken on. I have made it a mission to try to educate and bring the awareness and the information to the community. Thank you, guys.
Thank you, Lyssy. I wonder if you panelists want to ask each other any questions before we take questions from the audience. And I do have one question for you, Lyssy. There you were, in this desert of lack of information. How did you find your way into the hearing health community? How'd you find your audiologist?
To the audiologist, to my surgeon. I did, and I still continue to do the little research that I can to gather all this information. Unfortunately, my organization is still very, very small, So there's still tons of information that we need to bring into the community, but basically it's just connecting to other people that are willing to give me information, even when they hand me pamphlets and they say, well, I can give you 20 pamphlets, you know, from my organization. And I read those pamphlets, and I also learn through those pamphlets. So that's where I'm getting my information. Basically, from everywhere I can get it.
Karen and Diane, do you have questions of each other or of Lyssy?
I don't have any questions. I do have some thoughts about, why maybe these things might be happening, but I kind of want to, kind of open that up. I don't want to start spilling all that, until I give the attendees an opportunity to ask those questions. But no, I don't have any questions though.
And actually, I jotted down a question for Diane. I was going to contact her later about her study, and I can't find my note right now, so I'll reach out later. But thank you so much for sharing, Lyssy, from your perspective. And absolutely, I know there tends to be a different comfort level when you find the healthcare practitioner, as I said, who looks like you, who you think you share a common background. I don't have to explain some things we mutually understand. But then and I think there's great value in you helping to get others into the hearing healthcare arena and to find services. The comment that I made about also looking for the practitioner who is culturally responsive. To me, that, yes, I want to see more and more diversity among my colleagues. And again, I'm blatantly in support of all audiologists, and I want to see more diversity. But I also know we can't carry or meet the healthcare needs of all of the racial ethnic minority populations. And also, I think that is a shared professional role. So it's a dual. I also want all audiologists to be culturally responsive. So I know I did kind of a throw out there, and you're wondering, did she have a question there? But it was more an overarching comment. So I want to see more racial ethnic minority patients, but we have to come at it, in my opinion, from both perspectives.
Okay, I'm going to try to call, and some people have their hand.
I wasn't
the
sure why
first
everybody was raising their hand to me. I'm like,
okay, we have a lot of hands raised, and we have some electronic hands raised, and that's because for some of us, the raise hand isn't working. So I'm going to start, let's see. Okay, I want to, we'll go in this order. We'll start with John, Taylor, then David, then Tony Accalucci, then down to Karen Fraser, Lyssy herself, Kate Feller. Did I catch everybody? Okay, so if you can remember who you follow, just when that person finishes, speak up.
Thank you, Catherine, and thank you to all three of you. They were terrific presentations. And Lyssy, congratulations, and thank you for all the terrific work you're doing. I do have just a couple of questions, one for Karen and one for Diane. Karen, is there much research being done on the relationship between melanin and skin pigmentation and hearing loss? Because I've read that there are relationships. And my question for Diane has to do with the results on the hearing in noise. The sentences in noise is really, really striking. And I mean, I assume when you have more AZ bio sentences, you will follow up on that. Are the AZ bio sentences, however, simply translations? The Spanish AZ bio sentences simply translations of the English, or is there something to make them, more appropriate for Spanish speakers? Those are my questions. Thank you.
Yeah, I'll start. I am not aware of a specific study. I do know that is an area looking at the amount of melanin and its correlation to hearing loss. I do know that is something that is being looked at. Ironically, when I was a graduate student many, many years ago, that concept was introduced to me. And in all honesty, it personally was not well received because I was the only Black student in the program. And I thought, and they kept giving me all of the minority topics. And at the time, in your 20s and you are ready to do great things and conquer the world, I just wanted audiology. So it was just ironic that you said that. But again, I'm not aware. A general comment about disparities. A lot of the research studies, unlike what Diane is doing, do not look at race and ethnicity. So when the result, either those patients' clients are not included as subjects, or when they are, they're not identified as such, and it's not pulled out as a factor that should be considered.
John, in terms of the AZ bio sentences, yeah, we're in the middle of trying to crank some of that research out right now. And like I said, the University of Miami has a paper out on that already, and our findings here recently are similar to what they found, in that it seems as though Spanish is easier to hear. Although I do have to point one thing out with the current Spanish AZ bios, is that it is so when the sentences are presented and there's noise in the background, that babble noise is typically, so for example, like in the English AZ bios, the noise, the babble is in English as well. For the Spanish AZ bios, the babble is not in Spanish. It should be, but it's not. It happens to be in English. This is not at all a dig at the scholars who came up with with those sentences. This is where we start in science. You have to start somewhere, and that's okay. But it is a limitation. So the babble is in English, and the sentences are in Spanish. So that could be a factor as well. And in terms of the translation, I've listened to the Spanish sentences several times because we're testing participants here for that. And so not all of them are exact translations, but there are a few. There are a few sentences that are translated from the English AZ bio. So.
Thank you. Just to follow up on the hints versus AZ bio and noise, is the babble also in English on the Spanish hints?
So the hints don't have, well, gosh, I don't even remember what the English hints had, because I had nothing but Spanish speakers on my caseload. But the Spanish hints did not have a babble. It was just a noise, like a shh noise.
So not really comparable. Not really comparable. Those.
It's not.
Yeah.
It's not. No.
Thank you.
Yeah.
David?
Yeah, so I wanted to follow up. It wasn't addressed directly, but Lyssy's description of her experiences in New York seemed to contrast greatly with Diane's experiences in Southern Florida. And I wanted to ask, well, A, is that true? And if it is true, what can we learn? So let me be more specific. Lyssy described that in the Hispanic community here in New York, there's the information is less available. You see fewer Hispanics in the waiting room. They seem to be very underrepresented in the patient population. And based on my experiences in New York, I'm not surprised to hear her say that. That's what I expect to hear, unfortunately. Now, you didn't talk about this directly, Diane, but you did talk about your caseload, which was very heavily Hispanic. The majority of the Hispanics, at least in your studies, I don't know if it's true in your caseload, were Spanish speaking. I was wondering, I'm not sure if I should ask you about the Hispanic population or the Spanish speaking population, but are they appropriately representative relative to their percentage in the local community in your practice?
Well, for my caseload, it was, but Miami is about 70% Hispanic, and my caseload was about that. It was about 70 to 75% Spanish speakers.
And really dumb question. When you say your caseload,
Uh-huh.
is that because you were a Spanish speaker and therefore you got them versus the university where it would not be so much overall, or is that a representation of the university?
Correct. Well, actually, no. Yeah. So it was my caseload. So there were two of us Spanish speakers. It was me and my colleague Sandra Velandia. And we were the only two Spanish speakers on the team. And her caseload was about as heavy with the Spanish speakers as well. But I want to say at the time there were 7 of us, 8 of us. But just between the two of us, like I had a 70, 75%.
So your 70% caseload, so the rest of the audiologists, other than you, the two of you, were testing primarily in English?
They were primarily English, yes.
So then I think you're telling me that maybe not your personal caseload, but in Miami, overall, the representation is also similarly poor. Is that correct?
I would say so. I would say so. I mean, yeah,
That's-
yeah.
Okay.
It could definitely underpenetrated, that's for sure.
Okay, that's unfortunate. I was hoping to get some information to you about why your penetration was better than our penetration, but maybe it's not. Okay.
Yeah, and I think Dr. Gefeller put this comment or question in the chat a second ago about and I really think that some of the access could be, what we talked about earlier in the presentation is that, it may be that the hearing loss is not as noticeable in the Spanish speakers. And so it may take them a while to come, to go and get tested as opposed to the English speakers.
Great. Thank you.
I think there are questions in the chat that I'm not following. So David, could you maybe keep an eye on the chat? And for now, we'll move on to.
Sure. They're mostly comments, but I'll skim through it, but yes.
Okay. I think Karen Fraser was the next speaker out her hand raised.
Hi. Hi, everybody. I want to thank you for this presentation because it's very much needed. Just to give a little background on myself, I'm hard of hearing. I've been hard of hearing since kindergarten. And I'm from Brooklyn, New York. So I have experience of what it's like, coming up, being a hard of hearing person of color in New York City. Just to go back a little further, my mother is also Panamanian. She came from Panama when she was in the late 60s. I was born in the early 70s. Now, back then, from what I understand with my mom, I got sick. I had a high fever that caused me to lose my eyesight and my hearing loss. At that time, of course, my mother didn't speak Spanish to me. She's very fluent in Spanish, but she never spoke to me in Spanish. I guess due to me having a hearing loss, she wanted me to learn to speak English. So I grew up in a household of people speaking to me English. I don't know sign language or any of that. I grew up in a speaking household. Now, throughout my whole education, I was always in regular classroom. I was never in special ed or anything like that. But I've been fortunate enough to have what they call a resource room, where you come out to class for 1 hour and sit with someone and a speech therapist. It was like that throughout elementary all the way to high school. Then when I went to college, I was able to get like a note taker, someone to write notes for me and stuff like that. But it wasn't until high school that I came across, I went to Edward M. Murray High School. I don't know if you're familiar with that high school. They have a program there for people that are deaf and hard of hearing. So that was the first time I actually came across other people of color that was deaf and hard of hearing. But when it came to audiologist services for hearing aids, speech pathologists, and all that, I never seen. I'll be 52 tomorrow. I've never seen a person of color in that field at all. I always had white men. It wasn't until I switched job to a city job and my insurance changed, I ended up with who I have now, which is very nice, a white lady who's an audiologist for the city. But I could tell you that over the years of dealing with all these different audiologists, I've got into it with some of them, because I felt that I was not getting proper services. I was not getting good hearing aids. When it wasn't until like as I got older and I came across a few, non-Black hard of hearing people, and I realized, they was hearing a little bit better than I was. And I used to question what kind of health insurance do they have and how are they paying for the hearing aids and whatnot and stuff. So in the beginning, of course, back then it was Medicaid. I had Medicaid through my mom, and then years later when I got a job, it was through my job insurance. Today I have DC 37, but it's like over the years I felt that I was not getting proper hearing aids to help me hear better, and it's like you can hear sounds, I can hear the sounds and everything, but sometimes you can't hear the conversation too well. And there were times when I wanted to, like in the Black community, of course. Now, Karen mentioned, I'm aware of the National Audiologist, Black Audiologist Association, but I want to know, where are these audiologists, Black audiologists, because they're not in New York. I don't see them. And it's true when you say a lot of Black and Latinas, they don't go for hearing tests. I mean, I've had conversation over the years with my friends that have kids and stuff. They will go take their children for physical checkup. They get their eye check, body check, and everything, but they do not get hearing tests. And a lot of schools in New York City, even my daughter's 33 right now, and even in her school, they did not do hearing tests. Back in my day, they did, but in the school today, they're not giving hearing tests to these children. And a lot of these kids wearing headphones and things in their ears and all of that, but they're not getting hearing tests. So what I've always wanted to do is what Lyssy was doing. That's why I came on here, because I wanted to meet Lyssy, because she's in Harlem, I'm in Brooklyn, but I wanted to go toward more the younger generation. I want to do what you're doing, but for the younger people. Like, there's a lot of festivals and events out there, music events and stuff like that, but nobody's out. Okay, like when I go to different events, I would see a table set up for autism. Autism is like everywhere. You see that everywhere you go, it's always something for autism, but there's nothing to promote better hearing or to get hearing tests in our community, of course. And it frustrates me because I don't even have that much hard of hearing minority friends. I have very few, mostly from high school, but there's a lot of people in our community walking around half deaf. They can't hear, and they're not aware of the services, or they just don't want to get the services. I feel that there needs to be something done. I wish the Black Audiologist Association will be more present in New York City, to go out to these events. And I would do it myself. If I had the information, I would do it myself. Set up a booth where we can give out information, have a big tent with, saying, about hearing loss or whatever. And it would be nice to have something like a vehicle, like they have these trucks in New York City where you could go in and get like HIV tests or whatever. It would be nice to have something like that to give hearing tests that you can park at a festival or an event to encourage people of color to go get hearing tests, because there's a lot of lack of information that's out there, and everything is, like I said, is autism or some other type of even when you go on a cruise, it's autism, you know what I'm saying? There's nothing. I feel the Hearing Loss Association is, even the chapter in New York, they're not doing a good job, as far as representation comes. Because I went to in Manhattan, when they had the meetings in Manhattan, I went to twice. I was the only person of color there, except maybe I think the second meeting there was a Black man that was an audiologist or something. I don't think he was an audiologist. I can't remember. He was from the I forgot the name of the association in Manhattan, but there's really no,
I'm sorry. So Karen to Karen being inappropriate, I'm sorry, cutting you off, or interrupting, and I do apologize. So, but you brought up a lot of great points. As I said, there are only about 1,200 minority audiologists. So spread that across the United States, and you want to know where they are. They're very much scattered around. There's a lot of information that's available. In general, it's designed for audiologists and speech language pathologists to go into the community and share information. It's free information from ASHA. So maybe if you even partner with your audiologist and say you're willing to go into the community, the fact that you're standing at that table with that audiologist will help to draw folks in as well. That was just a thought that came to mind.
I tried that with another audiologist, actually two of them, before I have the woman that I have now, and that didn't work out. It's like they just more like they would give me pamphlets,
right.
to
Well, again, you have to find the person who is invested in being culturally responsive. They're willing to go into the community to reach out to different populations. And the other comment, and then I'll stop. You talked about access and disparities, and of course, that's the focus tonight. But we know there are healthcare disparities across almost every aspect of healthcare delivery. If we talk about maternal health, why do Black women die more often in childbirth than others? Why? So we can ask why, and they're contributing factors, but disparities exist across racial, ethnic populations, and that's a little bit of another deeper conversation.
Because I would like to go out more into the community, but again, it's like I need help. Like, where do I go if nobody wants to help me? You know what I'm saying? So that's the biggest issue I have, because I have no problem going out there, giving out information, setting up a booth. Usually it's no fee, but information needs to get out there, because there's a lot of people walking around, they can't hear. Then you have I have some friends that are from the West Indies, and they come over here, just so their children can get, hearing aids and hearing services. I mean, it's a lot that needs to be done and said and stuff.
Karen, can I answer a couple of your questions? First about trucks going around that you talked about, they test for autism. The Center for Hearing and Communication, which is a big hearing they do all sorts of different things. Then they work specifically with children, but also with adults. They have a mobile hearing test van. And if you can persuade some of your friends to come to our Walk for Hearing in September, the CHC van is always there. It's free. They have, very qualified audiologists. So big, New York is a big city. So, we have this van that goes around, but of course, how many people see it over the course of a year? And the other thing I want to say is that we have under with several people on our board are very involved with trying to get hearing screening reinstated in New York City public schools. You're absolutely right. This is a huge issue. There is a state law that requires hearing screening in schools in New York City is exempt. And John Taylor and Tony Acolucci and a couple of other people have been working on this. And so, if you'd like to help out with that, if you'd like to connect with Lyssy, we can, put the two of you together. It would be great to have you out talking about these issues.
Mm-hmm. I know
So
a lot of people, like the breast cancer work, that's very big. So I know a lot of people that do that, the breast cancer work in Brooklyn, and some go to Manhattan. It would be nice to have the mobile hearing van out there too.
yeah, I don't know. That's that's an interesting idea. They come to our walk because they know that that's anyway, sure, we can I'll suggest it. So I'm going to move on to I forget who had their hand up next. I think it was Kate Feller. Or was it Lyssy? Lyssy, you wanted to speak?
I think Tony was before me and maybe Lyssy, I'm not sure. I also put my question in the chat box. And so we could just go with that and let someone else talk.
That's okay, Kate. Why don't you speak? I don't need to ask my question. More important to have others speak up. So feel free.
Well, I was just, I loved that Diane talked about testing bilingual or primarily Spanish speakers on Spanish tests. And it does seem to me that it's a shame that there are not equivalent tests available for Spanish speakers, because that strikes me as an area that needs some work. But I was just wondering how the average person knows to go in and ask. I see Karen wrote a comment that there's a consumer bill of rights, and do patients know about that consumer bill of rights? Letting them know, having a really culturally responsive audiologist who says, what's your primary language? What would be best for me to test you in? But then how do you also have enough time when there are so many things to fit in and so many different tests to do? So I was just concerned about how a person who is bilingual or who is primarily a Spanish speaker has their best testing done and how they know what to ask for. And that, I mean, that's my concern.
Sure. No, yeah, thanks, Dr. Goodfellow, for your questions. Yeah, no, they don't know. And so that's where me and my colleague would come in and say, okay, well, you're bilingual, so am I. We're gonna do this in both languages. And so I had a couple of patients who were very adamant about not wanting to do the other language, but I said, you know what? We have to see how you're doing there, because that way we have a better, sort of more comprehensive picture of how you're doing. But we're trying to get there, Dr. Goodfellow. We're trying to, get those protocols hammered out right now. We're just not there yet, but right now it's basically just up to us right now, the Spanish speakers, to sort of push that until we can get that, we can start disseminating that information. But it is tough.
That seems a lot for you. And I guess my concern is also, in an hour, how much can you fit in?
Yeah, it is an issue. And so it is a time crunch, to be honest with you. There were times where I would test them in one language at one session and then test them in the other language at the other session. Sometimes I would just have to break it up. But sometimes I would just say, okay, well, thank God the patient after you did not come. They no-showed. We're just going to just use this entire time. So, we just play with the schedule in that way. It was not easy at all, but it was the best thing. And now that I'm on this topic, it actually brought about a lot of sort of heavy questions from the leaders, the administrative leaders on the team, right? So one of the biggest things, we talked about this at AAS in Scottsdale a couple months ago. I was facilitating a discussion in terms of diversity and inclusion in the clinic and how it impacts clinical work and how it impacts research as well. And so I had posed this sort of this scene to the group, and this is what happened with me at Miami. is that there were some leaders who they'd come to me and they'd say, Martinez, why is it that you're taking such a long time with your patients to get them from the cochlear implant evaluation to scheduling them for surgery? And so, so my patients, what it would look like would be, for example, they'd come for the cochlear implant evaluation, then the Spanish speakers, right? And then they want to go home and talk to the family, which that's what we do. So they want to go home and talk to the family. That's fine. And then we would schedule a telehealth appointment. And then so the patient was on the line and all their family members were behind them so that they could ask their questions. Then a third appointment was scheduled where the patient would come back. They'd say, yes, I want to do this, or no, they don't. If they did, that's when we would finally do the device selection. And so they're like, Martinez, why is it you're taking so long when the English speakers, they're having their evaluation done and scheduling surgery on the same day? I'm like, you haven't, like, what do you mean? You know, I don't know, I'm Hispanic, like this is what we do. And so there were a lot of very difficult conversations that were had, debates about, you know, what needed to be done. I said, well, culturally, this is, you know, this is what we do. So eventually leadership kind of changed their thinking. And so I don't remember how they changed it at Miami, but anyhow, but they eventually understood. But yes, there are many things to consider in addition to the language.
Lyssy, yeah.
I want to thank both of the speakers, Karen and Diane, for your wonderful presentation and a lot of information. My question is for Diane. Do you think that people that speak Spanish do better when they get their hearing tested with devices because the English language has more rules like the SH and the CH and the silent E? Can that be a factor?
Yeah, so we're thinking that yeah, that yes, in a nutshell, yes, that because Spanish has more syllables, there's more redundancy, so it's easier to pick up. And in Spanish, because there are more syllables, you know, even within a word, like the accents in the words also make it easier to pick up. Versus English, in English, there are more consonant clusters. And the consonant clusters can get washed out in noise a lot easier than the Spanish does. So yes.
That's fascinating. John, your hand is up.
Yeah, I don't know if we have time. It's because what the comment and question may take some time. I'll just throw it out there. And Karen mentioned using Bureau of Census categories. And those are actually overly broad. I mean, when we say Latino, Hispanic, that covers a huge number of different communities, Cuban, Puerto Rican, you know, Panamanian, I mean, all kinds of different communities that may have different attitudes about hearing loss. And that maybe some of those differences are reflected in the penetration of different communities. And I would love to hear some comments about that. And also for Diane, in the same light, do those different communities, is the Spanish all the same in all those communities? And you have to come up with tests that are going to reflect different dialects in all those communities.
Yeah, you're right. Yeah, it's there's a lot of work cut out for us. And you're right, it is a very mixed group of Spanish speakers, just thinking about here in Florida or, down in Miami, it's a mix. I mean, you've got the Cubans, all of Latin America is in Miami, and there's not just one accent, there are many. So yeah, a lot of work to do on that. I'm hoping that will change here soon. Even David's work, we need to start putting that into use as well. So.
And I was beginning to type a response, but I can hopefully more quickly say it. The Census Bureau recently has modified the response options. So you will see a different listing from which you can choose. In addition, expanding ethnicity. So there was a back and forth. MENA, for example, Middle Eastern, North African. Is that a race or is that an ethnicity? So again, you will see different response options the next time the US Census gathers information. One of the reservations about doing that, one, because we can't all decide, and also for comparative purposes. So if we've been gathering it using these categories, how do we shift? Is there truly a shift in the number, or people can now more accurately self-identify? Some people refuse to answer because it's kind of a social construct anyway. It's the way we think in the United States. If you go to France, they don't typically, and I just randomly chose that country, but outside of the United States, people don't think along the way we categorize people, but you will see more options and more of an opportunity to pick multiple, because many people, we often use the example of Tiger Woods, and he came up with, and I can't remember the word, but he said there are multiple parts to me, and I don't want to just pick one. I am multiple. I represent, or I am a combination of multiple races. And if you ask me my race, I want to be able to reflect all of them. I don't want to disrespect any part of me. So people are either forced to choose, or they won't answer at all anyway, because they can't find their box.
It's really interesting. David, did you have one? We have time for one more question, I think. Did you have one other question?
I do, very quickly. So Karen, I was truly, you had a slide where you looked at the racial and ethnic breakdown of ASHA, AAA, and AAO. And I thought that was extremely interesting. I'm wondering if you have similar stats that you could report for gender representation for those organizations.
We did not collect them, the dialogues group. I mean, I'm sure we can research it. I can readily give it to you for ASHA. And on that note, we have also changed our response categories. And there were lots of discussions and around. Typically through the years, you chose male, female. You can now choose non-binary as an additional option. On a related note, you can also identify your pronoun use. So we're trying to expand to be more inclusive so that, again, people can more accurately and comfortably represent. There are individuals who do not identify as male or female. So they either were choice to pick one, or they just didn't answer at all.
It's
so in the next
very
selection,
complicated.
the categories will be.
I think we've come to the end of our time. If nobody minds, so I just want to ask Karen Fraser one more question. How did you hear about this meeting? We really do try to reach out to different communities, and it's hard. I'm curious how you knew about this meeting. You're muted. You have to unmute yourself. Sorry.
Oh, okay. Yes, I got an email because I attended a chapter meeting in New York City, so I'm on the email list. So that's how they sent me the emails, and it showed about this meeting.
Oh, good. Okay. Well, I'm glad to hear that our emails are going out. So this is completely fascinating. I'm sure that we could all sort of go back and start all over again with these questions because they're so complicated. I really appreciate all of the speakers, and I also appreciate the people who come out and ask questions from the audience, because it's just a very fascinating and very provocative subject. So Lyssy, Diane, and Karen, thank you so much for your presentations and for being so open with your answers. And we would really love to try to expand our membership into communities that aren't now represented. So, talk to your friends, and we'll try to do programming that's appropriate. So anyway, so thank you so much to all three of you. And thank you to the people who attended too. So I think it's time to say goodbye. So if I didn't miss anything, I'm going to keep the chat so that I can look at it later and see what everybody put in the chat. Thanks so much. All right.
Thank you.